To whom much has been given, and we will see where the rest goes. I think you'll know where that comes from. And I'm a grateful recipient of much training. I had some pediatric training in CCBRT in Tanzania. That's there. I've had training in lots more ped surgery locally. Anesthetic skills have been brought to me by wonderful friends. And I don't know about you, John, but I have to do my own anesthetics. I hope you can do better than me, but that's me. And this is the Dean McGee team, which comes once a year. Did you see that, Brad? Are you there? Did you notice you're in there? But the Dean McGee team comes every year and bring fantastic skills. And the man, let me get the pointer. Third from the left comes out, and we've done some fantastic ped surgery. And of course, Dr. Farris has been our regular for neurosurgery, and of course the indomitable cataract surgeon from San Francisco. Is that right? With us. And so over the years, I've been benefiting from so many people who've benefited, taught me. And I just wanted to pass on to you the blessings of being involved in training. So if you're unconvinced at the end of this, then I don't think there's a lot of hope for you. But as I said to you earlier, it's part of every one of our responsibilities. I think that it's part of our Hippocratic oath that I will train others. And you have to have a heart of training. It really helps to have a heart of training. So let's just go for a little story up at the top end of Madagascar, a little spot called Sambava. And right now I have this sort of warm, mushy feeling in my heart because I trained one of those doctors there to do scleral tunnel surgery or MSEC, and there he is. That's another Madagascar doctor who I trained, and there they carry on. And I have this. One of my other hobbies, by the way, is beekeeping, and I don't know if anyone else does beekeeping, but you do, Stan. Great, we must talk. But I just love the idea when I'm sitting here and bellowing out. I know that there's a whole hive there who's busy out there and doing things, and I don't have to do anything. They're on autopilot. They're just getting honey for me. And in a way, that's the feeling you have when you've been involved in training, is that you've got these guys that you've trained, and there they are just going on. And all you have to do is provide the right environment and the right training, and it just keeps on going by itself. And rule number 6, we have 10 rules at our little hospital, and I shared that with you some years ago. I think it was at Atlanta. And that's rule number 6. Even a poor man is a gift to give. Even a poor hospital in Burundi can take on training and has taken on training. And even a poor, busy hospital like yourself or clinician like yourself can take on training. And some of the countries where we've been involved in training from. Now, the need, as you know, is a massive skills shortage at every level. And the projections for the future, if you look at the numbers, we've already seen some of the numbers for glaucoma, and that is quite staggering. But if you multiply that across all the fields of ophthalmology, it is truly beyond the means of our even current services to manage how we're going to cope once our world population gets older and more eye services. The demand is increasing exponentially. Added to that, we have attrition, which means nurses or doctors pass away or move to other fields or stop working, and obviously migration. It's a big feature in Africa. I think you need to know that. Is that there's a lot of inter-Africa migration and people looking for better jobs, better options, and will migrate from wherever, Kenya down to, Nairobi down to Johannesburg, and then on to Atlanta or somewhere. Seems to be a trend of people looking for economic advantage. And the more well they're trained, the better their chances are of migrating. And who needs training? Well, I've just got a list there, but it's pretty much everybody. There's always a need in a Vision 2020 program. In other words, a program that's signed on to the dotted line for providing comprehensive eye healthcare according to the WHO plan. There is going to be a skill needed at that place in administration. I'll tell you that one. That's a big one that still needs, besides all the others that I've mentioned there. The hardest ones to do are obviously in ophthalmology, and those skills don't come easily. That's a picture of my Swazi trainee, and Desmond is a lovely young man, and take great pride in having trained him. So, from whom much is given, much is required. And there's a big gap. I think we spoke a bit earlier about the academic approach that they've decided to do in Burundi. But you've got the university model versus the apprenticeship model, and the academic program versus a practical and grounded way of teaching. There's quite a big gap between the two. Once people are university trained, and by the way, most developing countries, the people love to have a certificate or need a certificate, because that means a career path, it means an income, great chances of income or even migration. So there's this battle. I still have this battle. I don't know about others of you. If you train someone and they get the diploma or they get the fellowship or something, they're out of your program because they want to move on somewhere else, because there's this upward drift always, or they go to the big city. And so there's a great strength to be had in the apprenticeship model on the practical and grounded side. And that's really what I want to talk to you about today, because the academic side is being done. And there's a lot of programs throughout the world that are taking care of that, but there's not a lot taken care of on the ground stuff, the small stuff on the ground. And that's where COS will come in. So what are the attributes of a trainer? Well, you've got to have a love for teaching. You've got to want to do this. You've got to be generous in your spirit to share information, to maybe to travel out to Haiti on a regular basis. You have to be flexible, because you're going to go there and see tumors that you haven't seen before, or you're going to see conditions that are just that you've never worked with this kind of instrument before, or you've never had such a blunt scalpel before. Just be flexible. And obviously, continuity. I think that's the message that I've heard a number of times today. You can't do this without good continuity. Some countries do not have an enabling environment, and that's a sad thing to say. But some countries seem to want to close the door for all, or not only countries, but hospital or mission agencies. They seem to want to keep you out rather than in. And sort of a life motto for me has always been, do the easy things before you do the hard things. If it's really impossible to go into a place, it's going to make your job incredibly hard, unless God has really called you to go to that place to be a trainer. But some places have a good enabling environment. What I mean by that, I mean registration with the council of that country is easy or not necessary. The hospital itself enables you to do what you need to do by helping you with travel arrangements, accommodation, good email communications before you get there. The hospital itself has got an adequate teaching microscope, and you've got enough skilled people around you to do what you need to do to train. Or even the trainee that you've got is an enabler. And obviously collaborative, because it's perhaps not you on your own. You might be collaborating with other agencies. You may have in the neighborhood of your area, you might have Site Savers or CBM, you might have Fred Hollows Foundation, or any of the other number of organizations. And I put there in little letters, resources. You do need resources, but you don't need a lot of resources to be a trainer. You need more of the above than less of the bottom one. So in a discipleship training model, what's really needed? Well, obviously we've all heard it's an initial investment of time, not just a short time, but a bit of time that will cement a relationship and a friendship that will keep this training going. I think this is friendship-based. And the academic support, yes, that is important. And you need to be able to train, bring resources into that your trainee's life. Please don't forget, one of the big lessons we've been hearing today is to hear and learn from your trainee, or hear and learn from where you are going to do your mission. Perhaps your network of friends, of donors, of even source of intraocular lenses from your neighboring practice or something will be useful where you are. So introduce your training concept. This is so much more satisfying and long-lasting than a simple dash in and dash out type of mission. And I'd encourage you to look for opportunities to train. And obviously distance support, to keep supporting that person, your trainee, and supporting, or those of you who can't train yourself, maybe we should look at supporting others who train. And I see there's a very good discussion coming up in January on MSIC training in Dallas, which would be an idea for those of you interested that has been put together. It's out in the lobby. There's a pamphlet on it. So some of the common mistakes which trainers make. Here is a young medical student we're trying to set up a retinal photography unit. This is a difficult thing to do in a poor country, to do diabetic retinopathy screening. Just the common mistakes of the quick fix solution. This is an easy thing to do. Let's just give them this one little thing, and I'm sure it'll solve their problem. Technology, again, is not the answer to all requirements for healthcare in the third world. Really, it's perhaps the last thing on your list. Don't forget the cultural mistakes. You can wade into all sorts of problems. I must just tell you, now we're talking on tumors. We had a Rotary group who came out from India, of all places, to Swaziland to do surgery, and I got into trouble because they felt that I had torpedoed their project because there were no patients for them to do. But ultimately, they hadn't done any case finding. They expected someone else, whoever that someone was, to do the case finding. But so they didn't have much to do. So they were in the government hospital and trying to do things. They were all phaco surgeons from New Delhi. And I went to go and pay my respects and just to meet them. And I saw one surgeon doing something on an eye, and I said, what are you doing? He says, the lovely little accent, I'm taking out a granuloma. I said, that's not a granuloma, that's a squamous carcinoma, and have you checked his HIV status? Well, this guy leapt to his feet, pretty much just about abandoned that his workstation, because he'd been terrified of HIV, and here he was operating on one of them. And they didn't bother to find out what they were coming to. They didn't know that Swaziland is 26% of the entire population is HIV positive. They hadn't found out what they were wading into. They hadn't crossed all let alone the cultural barriers, just the knowledge of where they were going to work. We've mentioned sustainability and continuity. That needs to be addressed. And thank you, Glenn, for briefing us on the modern trend towards sustainability and where it's coming from. But what are the pearls of wisdom that I can give? Well, firstly is, where was that? My first thing is really to say is, as a trainer, you need to really be able to bond with your trainee. I would say that you need to have a very, very patient mindset to get through training someone to do MSIC. It's not an easy process. Or training someone to do any surgery, you need to spend time with them. You need to be able to clear your schedule a little bit. So for me, when I have a trainee coming with me, we try and clear the schedule so we don't have more than 20 patients, or just 10 would be enough. And my trainees are always moaning at me that I don't sit with them. I'm up and about and doing other things. Trevor's smiling, because just sit with me, they say. Just get through this operation with me. Don't get up and move. I want you at my side. And so just stick next to your trainee. You'll be surprised how much that calms the situation by you just being there. I know it's uncomfortable at the assistant microscope, but you need to be there. Just be there for them. So lastly, what kind of a trainer are you? Are you going to be a trainer in where you live? Are you training those around you? It's not just training ophthalmology students. It's not just training ophthalmologists. It's training at all levels. Thank you.